So picture this. You're looking at a scan and you see a Bosniak 4 cyst. That is a massive red flag. It's highly suspicious for malignancy and demands definitive surgical excision. We do not just sit around and watch these. On the flip side, if a board question describes a patient with a long history of heavy painkiller or NSAID use who suddenly presents with flank pain, your brain should immediately jump to renal papillary necrosis. The chronic ischemia from analgesic nephropathy literally starves the papilla. It's a classic, highly tested association. Let's piece together the ultimate clinical puzzle for renal cell carcinoma. Radiologically speaking, if you see a renal mass enhancing by 25 Hounsfield units on a CT scan, yeah, that's RCC until proven otherwise. Clinically, you've got to beware of the classic board trap, painless hematuria combined with a newly developed left-sided varicocele. Why does that happen? Because the tumor invades and blocks the left renal vein. Biologically, remember that polycythemia is the hallmark paraneoplastic syndrome here, all thanks to ectopic erythropoietin production. Clear cell is going to be your most common histology, and for sure it's genetically tied to von Hippel-Lindau syndrome. Now, what do we actually do about these? Well, for localized upper tract malignancies, the standard of care is all about preservation. If you've got a small renal mass, say under 4 centimeters, especially in a solitary kidney, your main goal is nephron-sparing surgery. So the correct answer is a partial nephrectomy to save that renal function. Furthermore, when you're investigating suspected upper tract urothelial carcinoma, don't mess around with lesser imaging. CT urography is your undisputed gold standard to visualize the entire collecting system. Moving right along to Section 2, urolithiasis and ESW. We are stepping into the fascinating and incredibly painful world of kidney stones. You are absolutely going to get tested on stone profiles, so let's break them down. Calcium oxalate monohydrate? That one stubbornly resists extracorporeal shockwave lithotripsy, or ESWL, because its crystalline structure is just incredibly dense. Now, if your imaging shows a radiolucent stone on a plain X-ray that suddenly lights up bright on a CT, you're dealing with uric acid. Infection stones, which often form those massive crazy staghorns, are built of magnesium ammonium phosphate, and they're driven by urease-producing bacteria. And fundamentally, the most common metabolic driver for calcium stones overall is hypercalciuria. Okay, so someone rolls into the ER just writhing in pain with suspected ureteric colic. Your absolute first diagnostic step is a non-contrast CT-KUB, kidneys, ureters, and bladder. Once you've got the diagnosis, your treatment pathway completely diverges based on the stone. For uric acid stones, potassium citrate is your biochemical weapon of choice to alkalinize the urine and literally dissolve the stone. But for a massive staghorn calculus, meds won't cut it. You have to use percutaneous nephrolithotomy, or PCNL, where you tunnel directly into the kidney for definitive physical extraction. Watch out, because here is a critical Viva trap. If your patient spikes a fever right after ESWL, what must you assume? You absolutely must assume an infected, obstructed system. This isn't a wait-and-see situation. It's a urological emergency demanding immediate urinary drainage, usually with a stent or nephrostomy tube, alongside broad-spectrum antibiotics. And statistically, when you're tracking a stone's journey, they most frequently get stuck at the narrowest point of the ureter, which is the vesico-ureteric junction. All right, Section 3, bladder and prostate. We are moving down the anatomical pathway into the lower tract. Geographically speaking, the prostate is basically a tale of two distinct pathologies. Benign prostatic hyperplasia, which is the leading cause of bladder outlet obstruction in elderly men, aggressively chokes the urethra from the inner transition zone. Prostate cancer, however, hides silently out in the peripheral zone, which is exactly why a simple digital rectal exam can often palpate it. And when prostate cancer spreads, it classically and very painfully metastasizes to the bone, forming osteoblastic or bone-forming lesions. You've got to know your BPH toolkit inside and out. Tamsulosin relaxes the smooth muscle at the bladder neck, which is great for flow, but it frequently causes retrograde ejaculation, so you absolutely must warn your patients. Finasteride takes a totally different approach. It's a 5-alpha reductase inhibitor that actually shrinks prostate volume over time. If medical therapy fails and you get refractory urinary retention, that is an absolute indication for surgery, like a TURP. Oh, and one more thing, never jump the gun on an elevated PSA right after an episode of urinary retention. The retention itself spikes the PSA. You have to wait for it to resolve and then repeat the test. When it comes to the modern evolution of prostate cancer care, you can expect to be tested heavily. Remember, you cannot diagnose prostate cancer on imaging or a high PSA alone. The undisputed gold standard is always a histopathological biopsy.
If the disease is metastatic but still hormone sensitive, your initial systemic treatment is androgen deprivation therapy. And what if the patient had a prostatectomy but their PSA starts creeping back up? That's a biochemical recurrence. Today, we hunt down those microscopic lesions with highly advanced PSMA PET-CT imaging.
Switching gears to the bladder, there are 4 absolute clinical rules you need to burn into your brain. First off, never, ever ignore positive urine cytology, even if the CT urography is perfectly clean. You must perform a cystoscopy with random biopsies to rule out carcinoma in situ. Second, if you spot hydronephrosis in a patient with muscle-invasive bladder cancer, that means the tumor has grown completely over the ureteral orifices. It's a grim sign of advanced disease and a very poor prognosis. Third, before you even think about operating on stress urinary incontinence, a urodynamic study is your gold standard investigation. Lastly, if a patient from an endemic area presents with painless terminal hematuria, always think of schistosomiasis.
Okay, Section 4, genitalia and urethra. Let's look at the external anatomy and see how it builds our complete clinical picture.
Board examiners literally love testicular tumors, so let's break down the definitive oncology markers. Seminoma is your most common overall tumor. But here's the trick to remember. In a pure seminoma, alpha-fetoprotein, or AFP, is never elevated. If AFP is high, you're dealing with a non-seminomatous component for sure. Choriocarcinoma is notoriously associated with massive spikes in beta-HCG. And listen, for any suspected testicular malignancy, the absolute first surgical step is a radical inguinal orchidectomy. Never, ever perform a transscrotal biopsy. It disrupts the lymphatic drainage and completely alters the staging. When treating epididymitis, a patient's age completely dictates everything. Actually, scratch that. Age dictates your empiric antibiotic coverage because the microscopic culprit shifts based entirely on demographics. In sexually active young men under 35, you're essentially treating an STI, most commonly chlamydia trachomatis. But in men over 35, it shifts to standard urinary pathogens, overwhelmingly Escherichia coli, often secondary to urinary stasis from things like benign prostatic hyperplasia. In this area, time is literally tissue. If a patient presents with sudden, severe testicular pain and an absent cremasteric reflex, do not sit around waiting for a Doppler ultrasound. That is testicular torsion until proven otherwise, and it demands immediate scrotal exploration to untwist the cord and save that testicle. Similarly, the gold standard for a penile fracture, which is a tear in the tunica albuginea, is immediate surgical repair to preserve erectile function. And for a quick bit of anatomical trivia, remember, the most common site for an anterior urethral stricture is the bulbar urethra. And that brings us to our final stop, Section 5, Urological Trauma and Emergencies. This is the high-stakes world where rapid, protocol-driven decisions save lives. In urological trauma, the order of operations is absolutely crucial. Doing the wrong thing first can destroy a structure. During a hysterectomy, the distal ureter is highly vulnerable as it passes right under the uterine artery. If you suspect an iatrogenic injury postoperatively, order a CT urography, but you must ensure it includes delayed images so you can actually see the contrast leaking from the ureter. In blunt trauma, if there's blood at the meatus after a pelvic fracture, stop what you are doing. Do not pass a Foley catheter. You must first visualize the integrity of the urethra by performing a retrograde urethrogram. For renal trauma, stability is your compass. If a patient takes a blunt hit to the abdomen but remains hemodynamically stable, your diagnostic gold standard is a contrast-enhanced CT scan. Statistically speaking, the most common injury you'll find is a simple renal contusion, which you just manage conservatively. However, if follow-up imaging shows a persistent urinary leak from a laceration, we manage it minimally invasively. You place a ureteric stent to decompress the collecting system and just let the kidney heal itself. Here's a massive pediatric urology board question. A baby boy with posterior urethral valves has severe bladder outlet obstruction. This leads to decreased fetal urine output, which causes oligohydramnios, or very low amniotic fluid. Now, the most fatal consequence of this isn't actually in the kidneys. It's pulmonary hypoplasia. The lack of amniotic fluid physically prevents the lungs from developing properly in utero, making this a totally devastating and highly tested complication. All right, picture this final clinical scenario. You get paged to the ward. A patient with gross hematuria has suddenly stopped passing urine, they're in severe suprapubic pain, and they are rapidly developing clot retention. Your immediate reflex action must be to place a large-bore 3-way Foley catheter and start continuous bladder irrigation. You've got to manually irrigate and flush those clots out before that bladder overdistends and potentially ruptures. Your very first crisis is a newborn who is seriously struggling to breathe. So the absolute crucial point for a congenital diaphragmatic hernia, which, by the way, most commonly happens through a left posterolateral or Bach-Deleck defect, is how you manage that airway. You've got to immediately secure it with endotracheal intubation and ventilation. But here's the kicker. What you absolutely must not do is reach for the bag mask. Bag mask ventilation is strictly contraindicated here. Why? Well, pumping air into the stomach and intestines, which are already herniating up into the chest cavity, is literally just going to further compress the lungs and make this emergency so much worse. Moving on, let's break down how we definitively diagnose other upper GI obstructions right after birth. If a newborn has excessive salivation, is choking on feeds, and your NG tube simply coils up in the upper chest, you are definitely looking at esophageal atresia. Specifically, type C, which includes a distal tracheoesophageal fistula, is the most common variant you're going to see. Now, what if you spot that classic double bubble sign on an X-ray? That is duodenal atresia. It's the most common cause of neonatal upper intestinal obstruction, and it is highly associated with Down syndrome. Finally, if your neonate presents with bilious vomiting, you must assume it's malrotation with volvulus until proven otherwise. This is a massive surgical emergency. Your gold standard investigation here is an upper GI contrast study, and the definitive treatment is the LAD procedure. Let's pivot slightly to a different but very classic presentation: hypertrophic pyloric stenosis. When a baby is aggressively vomiting stomach contents over and over again, they're losing vital acid and electrolytes, right? This leads to a highly characteristic, incredibly heavily tested lab finding: hypochloremic, hypokalemic metabolic alkalosis. Say that 5 times fast. To confirm your suspicion, the best initial investigation is an abdominal ultrasound. And once confirmed, and obviously once you've properly resuscitated the patient, the definitive surgical treatment is a Ramstad pyloromyotomy. All right, moving into section 2, lower GI and intestines, specifically looking at obstructions and bleeds. As we move further down the digestive tract, you'll see the clinical pictures change pretty dramatically. So, here's a classic scenario you will absolutely face on the wards. If a term neonate fails to pass meconium within their first 48 hours of life, what is the most likely culprit blocking that lower tract? The answer is Hirschsprung disease. It is definitively the most common cause of neonatal lower intestinal obstruction. The core issue here is actually histological. There is a complete absence of ganglion cells in the affected bowel segment, which basically means it just cannot relax to let stool pass. And because this issue is microscopic, your gold standard investigation has to be a tissue sample, specifically a rectal suction biopsy, to actually prove those ganglion cells are missing. But wait, here is a really critical distinction to lock in for your exams. Keep in mind that while Hirschsprung is the most common lower obstruction, and duodenal atresia is the most common upper neonatal obstruction, jejuno-ileal atresia is actually the most common intestinal obstruction overall in the first month of life. Really distinguishing these superlatives is exactly how you ace that clinical viva. Now let's compare 2 major conditions that can cause significant distress and bleeding in the lower tract. First up, intussusception, famous for presenting with current jelly stool. In infants, the most common lead point causing the bowel to just telescope into itself is idiopathic hypertrophied Peyer's patches. And the incredibly elegant first-line treatment for a stable patient here, it actually isn't a scalpel, but an air anima reduction. On the flip side, we have the Meckel diverticulum, which is totally governed by the famous rule of 2s. It's the most common pathological lead point for intussusception in older children, but it typically presents on its own as the most common cause of painless rectal bleeding. Bleeding is definitely its most frequent complication, and to find it, your gold standard investigation is a technetium 99M per technetate scan. Before we leave the intestines entirely, we have got to address a true terror of the premature nursery: necrotizing enterocolitis, or NEC. This is a massive, incredibly high-yield topic. It's actually the most common cause of pediatric short bowel syndrome, simply because of the sheer extent of bowel that often ends up needing to be resected. Diagnostically, you are hunting for pneumatosis intestinalis, which is air within the bowel wall, on an X-ray. If that bowel perforates, NEC suddenly becomes the most common cause of neonatal pneumoperitoneum. If you manage to catch it before perforation, your initial treatment must be immediate bowel rest, NG decompression, and IV antibiotics. Section 3. Abdominal wall defects. Stepping back from the inner intestines for a second, we now need to evaluate congenital defects of the abdominal wall itself. Always keep in mind that while we see these super dramatic surgical defects in all our textbooks, a simple, uncomplicated umbilical hernia is actually the most common overall abdominal wall defect you're ever going to encounter in pediatric patients.
However, when you do face those more dramatic defects, examiners absolutely love testing this specific comparison. You must be able to instantly distinguish an omphalocele from gastroschisis. Omphaloceles possess a distinct covering membrane over the herniated organs, and they are highly associated with other broad congenital anomalies. Gastroschisis, conversely, lacks any covering membrane whatsoever. The bowel is just exposed directly to the amniotic fluid, and it is explicitly tied to intestinal atresia.
All right, on to Section 4, pediatric solid tumors and hepatobiliary. Next up on our shift, we transition away from structural defects to handling palpable masses. When you palpate an abdominal mass in a child, two heavyweights should instantly jump to mind. First is the neuroblastoma, which happens to be the most common tumor in infancy overall. The absolutely crucial dividing clinical point here is the midline. Neuroblastomas commonly cross the midline of the abdomen, and they're chemically marked by elevated urinary VMA and HVA. In sharp contrast, a Wilms tumor is specifically the most common malignant pediatric renal tumor. Unlike the neuroblastoma, it usually does not cross the midline, and it is very closely associated with WAGR syndrome. Now, looking at the liver and biliary tree, there are two major pathologies you really need to lock in. For the most common pediatric liver malignancy, which is the hepatoblastoma, you must inextricably link it to an elevated tumor marker, alpha-fetoprotein, or AFP. Meanwhile, if you are presented with a symptomatic choledochal cyst in a biliary tree, you really need to know the surgical fix. The gold standard treatment isn't just a simple drainage, it actually requires complete cyst excision followed up by a Roux-en-Y hepatojejunectomy for proper reconstruction.
Section 5, Urology and Anorectal Malformations. We are finishing up our demanding surgical shift by evaluating these systems, which are pretty ripe for both routine procedures and acute emergencies.
Differentiating scrotal presentations is absolutely key for preserving tissue viability. Now, hydrocele is the most common cause of painless scrotal swelling in children. It's typically benign and often just resolves on its own. But testicular torsion, that is the exact opposite. It is the most common cause of acute scrotum requiring immediate emergency surgery, and it's most commonly due to an anatomical variant known as the Bell-Clapper deformity, which unfortunately allows the testis to just twist right on its cord. And speaking of testicular anatomy, if you encounter an undescended testis on a routine newborn exam, you really need to know the proper timeline. 6 to 18 months of age is the absolute ideal window for the gold standard treatment, which is a surgical orchidopexy to bring the testis down and safely secure it. Finally, looking at anorectal malformations, the complexity of the surgery depends heavily on the specific anatomy. The absolute rule of thumb is that high lesions initially require a diverting colostomy to safely manage stool before any definitive reconstruction can even happen. And statistically speaking, if your patient is male, the most common type of anorectal malformation you'll encounter is a rectourethral fistula. Epidural versus subdural hematomas. Think about an epidural hematoma. It's got that classic lucid interval. The patient gets knocked out, wakes up, seems totally fine, and then boom, they rapidly deteriorate. Why? Because arterial pressure from a torn middle meningeal artery is rapidly expanding that bleed. Now contrast that with an acute subdural hematoma. When you look at the CT, you'll see this crescent-shaped hyperdense lesion. That's typically from tearing the more delicate bridging veins, so it's a slower venous bleed. So knowing your primary mechanisms totally dictates your diagnostics here. Take a diffuse axonal injury, or DAI. It stems from sudden acceleration deceleration. Picture a high-speed car crash literally shearing the brain's white matter tracts inside the skull. Because these lesions are microscopic, a standard CT just won't cut it. Your absolute best investigation is an MRI of the brain. On the flip side, we have cerebral contusions, basically brain bruises. These most commonly hit the frontal and temporal lobes, exactly where the soft brain tissue forcibly smashes into the harsh, bony ridges of the anterior and middle cranial fossa. Okay, the ICP monitor alarms. What do? Your clinical algorithm needs to be automatic. Step 1, elevate the head of the bed to 30 degrees. This optimizes jugular venous outflow. Still high? Move to your first-line hyperosmolar therapy, which is hypertonic saline. It creates an osmotic gradient that actively draws fluid right out of that swollen brain tissue. Now, if medical management totally fails, your definitive indication for a surgical decompressive craniectomy is refractory intracranial hypertension. You are physically removing a piece of the skull to give that swelling brain room to expand, literally preventing a deadly herniation. You've got to instantly recognize these physiological red flags. If intracranial pressure just keeps climbing, the brainstem starts to herniate, and that triggers the dreaded Cushing triad. You absolutely must have these 3 late signs memorized for your exams: hypertension, bradycardia, and irregular respiration. It's a massive warning sign for impending cardiovascular collapse. Alongside this, keep your eyes glued to the Glasgow Coma Scale. A GCS of 8 or less, that's the universally accepted threshold for a severe head injury. It is your absolute prompt to secure the airway and intubate. Remember the old rule, less than 8, intubate. Before we transition out of the trauma bay, let's talk cranial nerves and skull base. The most common cause of clear CSF rhinorrhea is a basilar skull fracture. You really need to hunt for specific signs on your physical exam. See battle sign, that bruising right behind the ear? That indicates a temporal bone fracture at the base of the skull. How about raccoon eyes, the bilateral periorbital ecchymosis? That points straight to an anterior cranial fossa fracture. And if you collect that clear fluid from the nose or ear and need to biochemically prove it's actually cerebrospinal fluid, beta-2 transferrin is your absolute best confirmatory test. Moving right along to Section 2, neuro-oncology and pituitary. So as we scrub into the OR, you have to know your tumor demographics cold for instant differential diagnoses. Notice how glioblastoma completely dominates as the most common primary malignant brain tumor in adults. But if we're talking about the most common primary brain tumor overall, which also happens to be the most common extraaxial tumor, that title goes to the typically benign meningioma. Now, looking down at the posterior fossa, an adult cerebellar tumor is most commonly a hemangioblastoma. But flip the demographics. If a child comes in with a midline cerebellar mass, the most likely culprit is a medulloblastoma, making it the most common malignant brain tumor in the pediatric population. Let's dive into some classic radiological markers. Brain metastases don't just pop up randomly. They classically lodge right at the gray-white matter junction. Why? Because the sudden narrowing of blood vessels there physically traps tumor emboli. And the primary cancer most commonly metastasizing to the brain, lung carcinoma. When you're evaluating a suspected meningioma on an MRI, always look for its classic feature, the dural tails sign. It shows dural thickening right next to the tumor. Finally, if you've got a patient with bilateral vestibular schwannomas, you must immediately link that to a genetic diagnosis of neurofibromatosis type 2. No exceptions. Okay, let's look at the sella turcica. The most common site for a pituitary adenoma is the anterior pituitary gland. Due to the tight local anatomy, when these tumors grow upward, they directly compress the optic chiasm. This gives you that classic visual field deficit, bitemporal hemianopia, where you lose your outer peripheral vision. Now, if that exact same patient suddenly develops a thunderclap headache, rapid visual loss, and ophthalmoplegia, you're dealing with pituitary apoplexy. It's a life-threatening hemorrhage right into the tumor, demanding immediate intervention. For symptomatic adenomas in general, your gold standard treatment is transsphenoidal surgery, safely accessing and resecting the tumor through the nasal cavity. As we prepare to scrub out and head over to the neurocritical care unit, there's a vital, high-stakes question every neurosurgeon dreads. A patient survives the initial bleeding from a ruptured aneurysm. Great. But what is the absolute worst complication that predictably strikes 4 to 14 days after a subarachnoid hemorrhage?
That brings us right into Section 3, vascular and hydrocephalus.
The answer to that terrifying 4 to 14-day window is cerebral vasospasm. Let's trace the pathology here. The most common cause of a spontaneous subarachnoid hemorrhage, or SAH, is a ruptured Barry aneurysm. And the most common spot for that aneurysm to form, the anterior communicating artery. To get a perfect look at it, your gold standard investigation is digital subtraction angiography. Now back to that nightmare complication. Cerebral vasospasm happens when the irritated blood vessels physically clamp down, which can cause massive ischemic strokes. The only drug actually proven to reduce the morbidity of this vasospasm is nimodipine, a calcium channel blocker. When you're managing fluid buildup in the brain, understanding the underlying mechanism is everything. Because the physical blood from an SAH clogs up the arachnoid granulations, a subarachnoid hemorrhage is actually the most common cause of communicating hydrocephalus in adults. The ventricles are still connected, but the CSF just can't be absorbed. On the other hand, if you're looking at obstructive hydrocephalus, where fluid is physically blocked from flowing within the ventricular system, the definitive treatment is usually a ventriculoperitoneal or VP shunt. There's a really cool exception though. For aqueductal stenosis, the preferred elegant treatment is an endoscopic third ventriculostomy. This bypasses the block entirely without leaving any permanent hardware in the patient. All right, home stretch. Section 4, spinal pathologies and trauma. Forming your spinal differential diagnosis relies strictly on knowing your anatomical compartments. The most common spinal tumor overall in adults, and specifically the most common extradural tumor, is metastatic carcinoma. If the tumor is growing physically inside the spinal cord itself, meaning an intramedullary tumor, your most common pathology in adults is an ependymoma. By contrast, the most common intramedullary tumor in kids is an astrocytoma. Lastly, if you're looking at a benign mass located inside the dura but outside the cord, an intradural extramedullary lesion, that's most commonly a meningioma. You need absolute unflinching clinical recognition for this next one. If a patient presents with lower back pain, bilateral leg weakness, saddle anesthesia, and urinary retention, you are looking straight at cauda equina syndrome. Guys, this is never a wait-and-see scenario. This is a massive surgical emergency. It requires immediate decompression if you want to save permanent bladder, bowel, and lower extremity neurological function. Rounding out our call shift, let's lock in some rapid-fire clinical anchors for your exams. Patient on anticoagulants suddenly gets severe back pain and paraplegia? Your top suspicion has got to be a spinal epidural hematoma. For literally any suspected spinal cord compression, the gold standard imaging is always an MRI of the spine. Moving to degenerative issues, the most common level for lumbar disc prolapse is L4, L5. But here's a classic Viva trick they love to pull. An L5, S1 disc prolapse usually compresses the traversing S1 nerve root, not L5. Don't let them catch you on that. Finally, if an elderly patient with cervical spondylosis falls and suffers a hyperextension injury, they'll classically develop central cord syndrome. You'll see upper limb weakness that's way worse than the lower limbs, often in a cape-like distribution.
So when we look at this anatomical region, patient age pretty much dictates our entire surgical approach. This is brilliantly illustrated by how we manage the Gardner classification for intracapsular femoral neck fractures, the classic elderly hip fracture. If you've got a displaced fracture in a 75-year-old, the standard go-to is a hemiarthroplasty. We just replace the ball. But take that same displaced fracture in a healthy 55-year-old, they need a total hip arthroplasty for the longevity of the joint. Now, what if it's undisplaced? Well, regardless of age, if it's undisplaced, we actually try to save that native joint using internal fixation with cannulated screws.
Now, you might be wondering, why are we so aggressive with treating intracapsular fractures? It's all because the blood supply in that specific region is just incredibly tenuous. The absolute most common complication you have to watch out for is avascular necrosis, where the bone tissue literally dies because it's starved of blood. It's a huge deal.
Okay, let's see how hip pathologies play out in pediatrics. If a child comes in with slipped capital femoral epiphysis, or SCFE, they need immediate in situ pinning. We have to stabilize that growth plate right away. Contrast that with Perthes disease, which classically shows up in kids aged 4 to 8. And as a quick rule of thumb, if you ever suspect avascular necrosis of the femoral head in any patient, your gold standard scan is always an MRI.
Moving right along to Section 2, infections and bone tumors. Let's walk through the acute osteomyelitis cascade. The bug you'll see most often is Staphylococcus aureus, and in kids, it notoriously targets the metaphysis of long bones. Now, pay close attention here, because exams love to trick you on diagnostics. The early gold standard investigation is an MRI. But the gold standard for a definitive diagnosis? That requires actual tissue. You need a bone biopsy with culture. Don't mix those two up. When it comes to bone tumors, the secret is categorizing them by age and precise location. Overall, the most common primary malignant bone tumor is multiple myeloma, but in children, it's osteosarcoma. Your most common benign tumor is an osteochondroma. Now, anatomically, both osteosarcoma and giant cell tumors really favor the area around the knee, but they pick different spots. Giant cell tumors love the epiphysis. Osteosarcoma hits the distal femur, and Ewing sarcoma, that one strikes right in the diaphysis, or the shaft, of the long bone.
You absolutely have to memorize this classic radiological visual language. If a question gives you Codman's triangle, a sunburst appearance, or an elevated ALP marker, boom, lock in osteosarcoma. If they describe an onion skin appearance, you're looking at Ewing sarcoma. And if you read the words soap bubble appearance, that is always a giant cell tumor.
All right, shifting gears to Section 3, upper extremity and hand.
Let's do a rapid-fire rundown of the nerves most at risk during trauma. Rattle these off with me. Anterior shoulder dislocation. That's the axillary nerve. Supracondylar fracture of the humerus. Anterior interosseous nerve. And finally, a posterior hip dislocation most commonly injures the sciatic nerve. Yeah, I know the sciatic nerve is lower limb, but grouping these high-yield nerve pairings together right now perfectly cements them in your brain. Let's quickly contrast our major joint dislocations. The most common direction for a shoulder dislocation is anterior, while for the elbow, it's posterior.
For those anterior shoulder dislocations, there are two specific defects you need to know. A Bankart lesion is damage to the anterior inferior glenoid labrum. A Hill-Sachs lesion, on the other hand, is a compression fracture on the posterolateral humeral head.
Moving down to the wrist, let's look at the distal radius, which is super commonly fractured. You need to distinguish between two classic presentations. A Colles fracture gives you that classic dinner fork deformity with dorsal displacement. Conversely, a Smith fracture creates a garden spade deformity due to volar displacement. Just visualizing those two household items makes remembering the displacement directions a breeze.
Here are some really high-yield hand and upper limb complications to keep in your back pocket. The scaphoid is the most commonly fractured carpo bone. But here's the catch. Its blood supply enters retrograde from the distal pole, so the most common complication is AVN of the proximal pole. Moving up to the elbow, the absolute most serious nightmare complication of a supracondylar fracture is Volkmann's ischemic contracture. And lastly, in a patient with a rheumatoid arthritis hand, the tendon that ruptures most often is the extensor pollicis longus.
Next up is Section 4, Knee Injuries and Sports.
For this one, I just want you to lock in the word medial. Burn it into your memory. The most common ligament injured in the knee? The medial collateral ligament, or MCL. And the most common meniscus injured? You guessed it, the medial meniscus. Medial, medial, medial.
When you suspect an ACL tear, you're looking at two tiers of diagnostics. The most accurate clinical test, meaning what you actually do with your hands in the exam room, is the Lachman test. But to confirm that tear definitively, the gold standard investigation is an MRI.
And that brings us to our final part, Section 5, Complications and Orthopedic Emergencies.
First up, open fractures. We categorize these using the Castillo-Anderson classification. When you're managing an open fracture, you follow a strict, non-negotiable four-step protocol. 1. Urgent irrigation. 2. Debridement of dead tissue. 3. Broad-spectrum antibiotics. And 4. Stabilization. Every single one of those steps is mandatory to save the limb.
Okay, I'm going to pause for a quick Viva check. I want to test your immediate recall on a highly tested, true orthopedic emergency. What is the earliest clinical sign of compartment syndrome? Take a second and really think about it.
Got it. The absolute earliest clinical sign is pain on passive stretch. And this pain is usually described as being way, way out of proportion to the actual injury. The most common site for this is the leg. If you see this sign, the gold standard treatment is an emergency fasciotomy. You have to release that pressure before irreversible muscle and nerve death sets in. Another terrifying systemic emergency is fat embolism syndrome. The most common cause is the trauma of a long bone fracture, which allows fat droplets to enter the bloodstream. Now, the earliest investigation suggestive of a fat embolism isn't an X-ray. It's actually a sudden, unexplained drop in blood oxygen, which shows up as hypoxemia on an arterial blood gas, or ABG.
All right, let's pose one final high-stakes question to wrap up this rapid-fire explainer. When a patient suffers a major pelvic fracture, what is the most common cause of death? The answer is hemorrhage.
Every surgeon needs a framework, and in our field, that is the reconstructive ladder. Now, what's really interesting here, and this is a classic Viva question, is where that ladder actually starts. They'll ask you for the very first rung, and the answer is simply secondary intention healing. Because sometimes the absolute best surgery is no surgery at all. But when we do need to reconstruct, what's our guiding star? Well, the single most important principle in reconstructive surgery is to replace like with like. You want to use tissue that perfectly matches the color, texture, and thickness of what was lost. That is how you ensure the best possible functional and aesthetic recovery.
So let's talk about actually replacing that missing skin by looking at our grafting options. This is a perfect test of clinical reasoning. On one hand, we have the split-thickness skin graft. This is your absolute gold standard for resurfacing large skin defects. If examiners ask for the most common donor site, it's the thigh. And the ideal dressing is a non-adherent pressure dressing that's crucial to prevent shear forces and fluid accumulation. Now, contrast that with the full-thickness skin graft. You are going to reach for this when you're dealing with facial and fingertip defects. Why? Because those areas require superior cosmesis, and a full-thickness graft provides a much better functional and aesthetic match. Think about this. Once you place a graft, it is literally cut off from its blood supply. So how on earth does it live? Board exams love testing the exact terminology of this biological timeline. In phase 1, the initial survival phase, a split-thickness graft survives through a process called plasmatic imbibition. It's basically drinking the nutrient-rich fluid right out of the wound bed. Then we hit phase 2, which is when the actual blood supply to the graft begins. This major milestone is called inosculation. That's when the blood vessels from the wound bed actually link up and connect with the vessels in the graft.
But look, grafts don't always take, right? We have to know the rules of graft failure. The absolute non-negotiable requirement for successful skin graft take is a well-vascularized wound bed. Because of this, a graft will straight up fail on exposed cortical bone without periosteum, and it will fail on exposed tendon without peritenon. But here's the catch. Even with a perfect wound bed, things can go wrong. And this is a massive high-yield fact. The most common cause of skin graft failure overall is a hematoma. Blood collects underneath, lifts the graft right off the bed, and it totally blocks both plasmatic imbibition and inosculation.
Moving right along to Section 2, flap dynamics and monitoring. So what is the crucial factor that defines a flap compared to a graft? It's that a flap survives because it brings its own blood supply. But not all blood supplies are created equal. We have random flaps and axial flaps. A random pattern flap is exactly what it sounds like. Its blood supply is completely random and depends entirely on the subdermal plexus. An axial flap, though, that is much more robust because it relies on a specific, named artery. Grasping this difference is absolutely fundamental when you're designing flaps. All right, get ready, because this is an essential matching table that is guaranteed to show up on your exams. These are the definitive gold standard flap reconstructions. Let's rapid fire through the clinical reasoning. Got a defect in the lower third of the leg? The gold standard is a free flap, simply because local tissue there is so scarce. Breath reconstruction? The DIP flap is your go-to, as it brilliantly spares the underlying rectus muscle. What about the head and neck? The radial form free flap gives you excellent, thin, pliable tissue. And the absolute best choice for mandibular reconstruction is the free fibular flap, thanks to its superior bone stock. Definitely memorize these pairings. This is pure high-yield gold. Now, I want you to picture this. You are on the ward. It's 2 a.m. A nurse calls you because a patient's brand new free flap just doesn't look quite right. Here is the clinical question you have to answer. What is the absolute best investigation for flap vascular compromise? Do you order an urgent Doppler? Maybe an angiogram? Actually, the answer is clinical examination. Yep. Despite all the advanced technology we have, your eyes and your hands remain the ultimate, absolute best diagnostic tools for assessing flap health. So, what exactly are you looking for during that 2 a.m. clinical exam? Well, you're trying to distinguish between arterial and venous compromise. If the artery gets blocked, the very earliest sign of arterial compromise is pallor. The flap goes pale because the blood simply isn't getting in. But let's look at the venous side. The earliest sign of venous compromise is congestion. The blood is getting in, but it can't get out. And please pay close attention to this point. Venous thrombosis isn't just the most common complication of free flap surgery, it is the single most common cause of flap failure within those critical first 72 hours. You have to watch for that congestion. Let's shift gears to Section 3, Pediatric and Congenital Anomalies. In pediatric reconstruction, timing really is everything. We have an ideal repair timeline to maximize a child's developmental outcomes. For a cleft lip, the sweet spot for repair is 3 months of age, and examiners will totally expect you to associate this with the classic rule of tens, meaning 10 weeks of age, 10 pounds in weight, and 10 grams of hemoglobin. On the flip side, the ideal age for a cleft palate repair is a bit later, usually between 9 and 12 months. This timing allows for optimal speech development while still protecting normal facial growth. Next up, I've consolidated all the highest yield congenital most commons for rapid-fire memorization. Ready? First, cleft lips present most frequently as unilateral left-sided. The classic craniofacial cleft syndrome you'll see is cleft lip and palate occurring together. When it comes to premature skull fusion, the most common presentation is sagittal synostosis. And finally, the single most prevalent congenital hand anomaly is syndactyly, which is that webbing or fusion of the fingers. Section 4. Trauma, bites, and infections. So, how does the specific type of tissue exposure dictate your reconstructive choice in trauma? Let's break this down. For any contaminated wound, your absolute earliest management step is always irrigation and debridement. If you're dealing with a facial laceration, the best route is primary closure, but only after really meticulous irrigation. Now, what about an exposed tendon? Remember our graft failure rules from earlier? A graft won't take on an exposed tendon without paratenon, so your best move there is flap coverage. Fingertip amputation with exposed bone? Go with a local flap. And here's a quick, high-yield anatomy trap for you. If you are doing carotid surgery, the nerve most at risk of being injured is the facial nerve. Let's talk about bites and severe infections. For any bite wound to the hand, the gold standard is a combo of irrigation, debridement, and antibiotics. But which antibiotics? You absolutely have to know the bugs. The most common organism in a human bite infection is Eikenella corrodens. For dog bites, it's Pasteurella multicida. And finally, let's talk about the most terrifying soft tissue infection, necrotizing fasciitis. The predominant bug causing this is Group A Streptococcus, and the absolute gold standard treatment is urgent surgical debridement. Seriously, do not wait on this one. Just before we leave trauma behind, we need to highlight one extremely dangerous complication of burns, eschar formation. Why is this so critical to know? Because eschar formation is the most common cause of compartment syndrome after a circumferential burn. That burned, inelastic skin basically acts like a rigid tourniquet. It prevents any swelling and fatally compresses the underlying structures. Catching this early and performing an escharotomy will literally save limb.
And finally, Section 5, Skin Oncology and Scars.
Here we're contrasting the high-yield behaviors of the two most heavily tested skin cancers. Basal cell carcinoma is the most common skin cancer overall, and you'll typically find it on the face. Melanoma, on the other hand, is less common but is the skin cancer most likely to metastasize. The single most important metric you need to memorize for melanoma is the Breslow thickness. Breslow thickness not only independently predicts prognosis, but it entirely dictates whether or not you're going to do a sentinel lymph node biopsy. Our final clinical concept is all about visually distinguishing between the two major types of pathological scarring. The key differentiator here is the margin. Hypertrophic scars remain strictly within the original wound margins. Because they're localized like that, your best first-line treatment is going to be a silicone gel or sheet. Keloids, however, are much more aggressive. They extend beyond the original wound margins and invade the normal surrounding tissue. So the best first-line treatment for a keloid is an intralesional corticosteroid injection.
I want to spark your active learning right out of the gate here. Ask yourself, what specific vascular pathology is driving our very first major exam topic? Think about it for a second. Well, the most common cause of a thoracic aortic aneurysm is atherosclerosis. You really need to keep that foundational fact in your back pocket as we start expanding on these aortic pathologies.
Now, while atherosclerosis drives thoracic aneurysms, the ascending aorta is a whole different beast. Aneurysms there are actually driven by cystic medial degeneration. You'll often see this in aging or in folks with connective tissue disorders. Now, in blunt trauma, rapid deceleration causes these massive shearing forces, which makes the tethered aortic isthmus the classic rupture site. For stable patients, always grab a CT angiography to confirm. And finally, look at this massive clinical divergence when it comes to dissections. Type A involves the ascending aorta and risks fatal tamponade, so that means emergency surgery, absolutely no question. But uncomplicated type B, that's distal, so we can rely on medical blood pressure control just to bring down that shear stress.
Okay, you have to memorize this classic VIVA definition. Beck's triad, that's hypotension, raised JVP, and muffled heart sounds. This is your immediate glowing red flag for cardiac tamponade and the trauma bay. And when you suspect it, your absolute best diagnostic tool is immediate echoardiography.
Crucially, echo is your gold standard for diagnosing both blunt cardiac injuries and tamponade. Once you actually confirm that tamponade, definitive treatment means you need surgical drainage via a pericardiotomy. And hey, in the context of penetrating trauma, like a stab wound, just remember your basic anatomy. The right ventricle sits right there, most anteriorly in the chest, making it the most frequently injured chamber by far.
Moving right along to Section 2, chest wall and pleura, respiration and drainage.
So for a suspected tension pneumothorax, your best initial investigation isn't actually an investigation at all. It's a clinical diagnosis. Literally never wait for an x-ray. Your immediate treatment absolutely must be needle decompression, and then you follow that up definitively with a chest tube. All right, let's rapid fire through some chest wall mechanics. The most common indication for a tube thoracostomy after trauma is a simple pneumothorax. Now, for stable blunt trauma, your gold standard imaging is a contrast-enhanced CT. Looking at the ribs themselves, the fifth rib is highly exposed, so it's the most commonly fractured. But contrast that with the first rib. That one is heavily protected by the clavicle, so if you see a fracture there, that strongly signals high-energy trauma. Finally, multiple consecutive broken ribs create what we call a flail chest, which causes paradoxical breathing. The definitive fix for severe cases of this, positive pressure ventilation to literally act like an internal pneumatic splint for the chest wall.
Burn this number into your brain right now. Greater than 1,500 milliliters. A massive hemothorax is strictly defined by an initial chest tube drainage of more than 1,500 milliliters. If you see that kind of output the second you place the tube, you're dealing with a massive, life-threatening hemothorax.
But what if the bleeding is slower, but it just keeps going? Well, your ongoing surgical threshold for a thoracotomy is persistent bleeding of greater than 200 milliliters per hour for 3 consecutive hours. So you monitor that tube, and if it hits that rate, you are taking that patient straight to the OR. No delays.
Let's shift gears to postoperative pleural complications. A chylothorax is most commonly caused by an iatrogenic thoracic duct injury. We usually manage this initially with just a conservative chest tube and a fat-free diet. But if it just won't quit, the gold standard fix is thoracic duct ligation. Now, shifting from lymphatic fluid to pus, acute empyemas are overwhelmingly driven by Staphylococcus aureus. If that infection organizes into a super thick, fibrous stage 3 empyema, the lung basically gets trapped. At that point, surgical decortication is your definitive treatment.
Section 3, Thoracic Oncology and Lungs. Staging and resection.
Let's put these essential lung tumor facts side by side. So adenocarcinoma is the most common primary malignant lung tumor overall. But if your patient has a heavy smoking history, squamous cell carcinoma is the classic histological finding. Lastly, it is absolutely vital to remember that small cell lung carcinoma is an aggressive, systemic disease right from day one. That means its primary treatment is chemotherapy, so we generally bypass initial surgical resection entirely.
For early-stage non-small cell lung cancer, or NSCLC, the clinical pathway is incredibly precise. The gold standard investigation for mediastinal staging is an EBUS-guided biopsy. That stands for endobronchial ultrasound. Once it's staged, the gold standard treatment for that early-stage disease is a lobectomy with a complete lymph node dissection.
Location matters so much in thoracic oncology. Take a Pancoast tumor, for example. It involves the superior sulcus, or the apex of the lung. And because it invades the nearby sympathetic chain, it classically presents with Horner syndrome. That's ptosis, meiosis, and anhidrosis. Definitely know that triad. Also, if an exam asks you for the most common cause of superior vena cava syndrome, you want to look for a right-sided lung carcinoma that's physically obstructing that major vessel.
Stepping through the management of malignant pleural effusions, we always start with therapeutic thoracentesis. That is your best initial management to just relieve the patient's symptoms quickly. But if it keeps coming back, pleurodesis becomes the definitive treatment for a recurrent malignant effusion. It essentially obliterates the pleural space so fluid just can't accumulate there anymore.
All right, Section 4, Esophageal Disease and Surgery, Perforations and Malignancy.
Boerhaave syndrome. This is the textbook definition of a spontaneous esophageal rupture. It is a hyperacute emergency that you need to recognize immediately, and it very often follows a bout of forceful vomiting.
If you even suspect an esophageal perforation like Boerhaave, your absolute gold standard investigation is a CT with water-soluble contrast. We use water-soluble to prevent severe mediastinitis if there's a leak. If you catch it early, the treatment is primary surgical repair. Now looking over at malignancies, squamous cell carcinoma is actually the most common esophageal cancer worldwide. But in the distal esophagus, which is really often driven by chronic acid reflux, adenocarcinoma reigns supreme. Localized carcinomas typically require an esophagectomy, and for those distal lesions, the classic surgical approach is the Ivor-Lewis procedure.
And finally, Section 5, Coronary and Valvular Procedures, the elective OR.
For elective cases, coronary angiography is still your best investigation for coronary artery disease. If that angio reveals left main disease, the patient's going to need coronary artery bypass grafting, or CABG. During a CABG, surgeons really prefer using the left internal mammary artery, or LIMA. Why? Because it offers the absolute best long-term patency rates, period. And when we shift over to structural heart disease, the aortic valve takes the crown as the most frequently replaced valve in the surgical suite.
Wrapping up our 50 facts, let's quickly talk about infective endocarditis that actually requires surgery. The most common causative organism driving these surgical cases is Staphylococcus aureus. But what exactly forces the surgeon's hand to operate right then and there? Well, the most common indication for emergency surgery in infective endocarditis is acute severe heart failure, specifically due to valvular destruction.
And initial signs. Okay, before our minds immediately jump to worst-case scenarios, let's look at the most frequent non-malignant presentations you're actually going to see in clinic on a daily basis. Let's do some rapid-fire facts. If you get asked for the most common benign breast disease overall, your answer is always fibrocystic changes. Now, if the question suddenly shifts to the most common benign tumor, or specifically the most common benign lesion in young women, you've got to anchor that straight to fibroadenoma. And what about a simple breast cyst that you've just confirmed on ultrasound? Honestly, the best management is usually just reassurance. You only want to aspirate if it's symptomatic or big enough to cause the patient discomfort. Definitely keep those distinct in your head.
You're also going to need to contrast some very specific symptomatic presentations. On one hand, you've got pathological nipple discharge. The most common cause overall, and especially if we're talking about a bloody discharge from a single duct, is an intraductal papilloma. Contrast that with lactational mastitis. The most common culprit there, good old Staphylococcus aureus. Your drug of choice is going to be flucloxacillin. Now, if you suspect it's progressed to a full-blown abscess, your best investigation is an ultrasound, and your preferred treatment immediately shifts to ultrasound-guided aspiration paired with those antibiotics.
Moving right along to Section 2, Diagnostics and Triple Assessment.
So let's see how this all builds into the essential diagnostic workup when a patient comes in with a concerning mass. The triple assessment is the absolute cornerstone of breast surgery. Step 1 is your clinical examination, Step 2 is imaging, and Step 3 is pathology. The crucial point here is that this entire protocol caps off with a core needle biopsy. Seriously, mentally highlight this. A core needle biopsy is the undisputed gold standard for achieving a breast cancer diagnosis. Why? Because unlike a fine needle aspiration, it actually preserves the tissue architecture, allowing you to confidently differentiate in situ from invasive disease.
Now think about this strict age divide for Step 2 of our assessment. When a patient presents with a lump, their age literally dictates your imaging choice. For women under 30 years old, their breast tissue is much denser, which makes mammograms really tough to read. So the best initial imaging is always a breast ultrasound. But for women over 40, the tissue tends to be more fatty, which means diagnostic mammography becomes your gold standard. You really want to burn this specific algorithm into your clinical reasoning.
Moving into advanced imaging, breast MRI is your most sensitive modality for high-risk screening. And when we consider mammograms, keep in mind that microcalcifications absolutely scream ductal carcinoma in situ, or DCIS. Encompassing all of this is the golden rule, arguably the most important principle in all of breast cancer management. Perform the triple assessment and follow it up with stage-appropriate multimodal treatment every single time.
Next up, Section 3, Malignant Pathology and Subtypes.
Here we go, navigating the complex histology and specific clinical presentations of malignant tumors. This is exactly where examiners love to test your specific pathological knowledge. So here are your carcinoma classics. If the examiner asks you for the most common malignant breast tumor or the most common histological type, your immediate go-to is invasive ductal carcinoma, no special type. And where is it most likely to be? The upper outer quadrant, hands down. But pay really close attention to this next point. If they mention a patient with bilateral disease or the pathology shows a classic single-file pattern of cellular infiltration, you need to pivot immediately to invasive lobular carcinoma.
Let's connect a few more clinical dots on specialized presentations. We mentioned DCIS earlier with those microcalcifications, right? Well, it is the most common precursor lesion for invasive ductal carcinoma. Next, if you see Paget disease of the nipple, you absolutely must know it's most commonly associated with an underlying ductal carcinoma. Finally, inflammatory breast cancer classically presents with the dreaded peau d'orange, skin that literally looks like the peel of an orange. Why does that happen? Because it's physically caused by dermal lymphatic obstruction from the tumor cells.
Now let's quickly map out the genetic landscape. The most common gene mutation associated with hereditary breast cancer is BRCA1. However, note how BRCA2 specifically links to an increased risk of male breast cancer. And speaking of male breast cancer, what's the most common histological type in men? It's invasive ductal carcinoma.
All right, let's head into the OR. Section 4, Surgical Management and Staging.
Let's break down the major surgical decisions and staging parameters based on the pathology we just covered. When deciding on a surgical approach, the tumor's distribution is absolutely key. For multicentric breast cancer, your best surgical option is a modified radical mastectomy. In fact, diffuse multicentric disease is an absolute contraindication to breast-conserving surgery. You just can't do it. On the flip side, if a patient is a good candidate for breast-conserving surgery, you are strictly obligated to follow that up with radiotherapy. You basically can't have one without the other.
This pathology also dictates a very logical, stepwise approach for how we manage the axilla. Step 1. If a patient has clinically node-negative invasive breast cancer, a sentinel lymph node biopsy is indicated. We really try not to clear the axilla unnecessarily. Step 2. If, and only if that sentinel node is positive with clinically significant nodal disease, then your gold standard management is to proceed to a full axillary lymph node dissection.
When we stage these patients, the gold standard for early breast cancer is TNM staging. But out of all the different factors we look at, never forget that the axillary lymph node status is your single most important prognostic factor for the patient's survival, period. And for those patients presenting with locally advanced breast cancer, this is where we primarily indicate neoadjuvant chemotherapy, aiming to shrink the tumor down before we even operate.
Let's look beyond the scalpel. Section 5, Systemic Therapies and Prognosis.
Time to explore systemic medical treatments. Today, systemic therapy is driven almost entirely by a tumor's receptor status. Now, note the precise terminology I'm using here. We just said lymph node status is prognostic, right? But the estrogen receptor, or ER status, is the most important predictive factor. It predicts exactly whether the tumor will respond to endocrine therapies like hormone blockade. Hormone receptor-positive breast cancer is fundamentally treated with this targeted endocrine therapy.
Linking specific receptor statuses to targeted therapies is an absolute goldmine for your exam prep. For ER-positive premenopausal women, the drug of choice is tamoxifen. If they are ER-positive but postmenopausal, you want an aromatase inhibitor. If the tumor comes back HER2-positive, we use trastuzumab. But watch out, the major adverse effect of trastuzumab is cardiotoxicity. Finally, triple-negative breast cancer gets its name because it completely lacks the expression of ER, PR, and HER2 receptors.
Almost at the finish line. Section 6, Complications and Disease Recurrence.
Our patient journey concludes with the post-operative phase. Remember, your job doesn't end when the incision is closed. You have to anticipate complications and monitor diligently for recurrence. So, put your attending hat on and ask yourself, what is the most common complication we face when we perform that axillary lymph node dissection?
Lymphedema is the answer. It's by far the most common complication following an axillary clearance, and your clinical antenna should go straight up the second a post-op patient reports its earliest symptom, which is arm swelling. Catching it early here can make a massive, massive difference in that patient's quality of life.
Let's talk recurrence. If the disease returns locally after breast-conserving surgery, the most common site is the ipsilateral breast. If it spreads distantly, the bone is the most common site for metastasis. In fact, breast carcinoma is the most common cause of osteolytic metastases in women. And if you suspect recurrent breast cancer, what is your first-line investigation? We come full circle. It's a core needle biopsy.
Okay, let's dive into this foundational workup. Whenever you see a patient with hyperthyroidism, lock it in. The most common cause is Graves' disease. But what if they present with a solitary thyroid nodule? Well, your gold standard investigation is always an ultrasound-guided fine needle aspiration cytology, or FNAC. Now, if that cytology comes back as Bethesda 6, which is the highest risk category indicating outright malignancy, the definitive treatment is a total thyroidectomy. But remember, while FNAC is fantastic for guiding our clinical decisions, the true gold standard investigation for actually confirming a thyroid malignancy is always the final histopathological exam of the resected tissue.
Now, what's really interesting here is how this perfectly organizes nearly 10 potential exam questions in one go. Let's contrast the big four thyroid cancers. Papillary thyroid carcinoma is the most common, and it spreads primarily through the lymphatics. Now, examiners absolutely love to test the unique spread of follicular carcinoma because it's hematogenic, meaning it spreads through the blood, with the most common site of distant metastasis being the bone. Then we have medullary carcinoma. This one is unique because it arises from the parafollicular C cells, meaning its tumor marker is calcitonin, and it's heavily associated with MEN2 syndromes. Finally, anaplastic carcinoma. This is the most aggressive thyroid cancer out there, which unfortunately means the best treatment is often just palliative therapy. Moving right along to Section 2, Complications of Thyroidectomy. A good surgeon isn't just someone who operates well. A good surgeon has to anticipate and rapidly manage complications post-op. So the crucial point here is knowing the clinical difference between these two scenarios on the ward. We're talking about recurrent laryngeal nerve, or RLN, injuries. If a patient has a unilateral RLN injury, they're going to present with hoarseness of their voice. But if there's a bilateral injury, you're looking at a completely different, much more dangerous situation, acute airway obstruction. That is a full-blown surgical emergency requiring immediate intervention. But the most common complication overall after a thyroidectomy actually isn't nerve injury, it's hypocalcemia. This is primarily driven by transient hypoparathyroidism, usually because the parathyroid glands get manipulated or stunned during surgery. If you're examining the patient, the most reliable early sign they'll report is perioral numbness and tingling around the mouth. You can actually confirm this right at the bedside. Check for the Trevostek sign by tapping the facial nerve to look for a twitch, or the Trousseau sign by inflating a blood pressure cuff to induce a carpal spasm. Both are classic indicators of hypocalcemia. And if the patient is symptomatic, your gold standard treatment is immediate IV calcium gluconate. And that seamlessly transitions us to Section 3, parathyroid and calcium management. It's a tiny organ system, but it has massive systemic effects. All right, here is a classic Viva trap that examiners love to spring on you. What is the most common cause of hypercalcemia? Well, the trick is that the answer completely changes based on where your patient is. If they're a hospitalized inpatient, the most common cause is malignancy. But if they're an outpatient rolling into your clinic, the most common cause is primary hyperparathyroidism. Context is literally everything here. Let's unpack those parathyroid facts a bit more. Primary hyperparathyroidism is most commonly caused by a single parathyroid adenoma. Your gold standard for diagnosis? A blood test showing the dual presence of elevated PTH alongside hypercalcemia. Once you've got that diagnosis, the most common indication for actually performing a parathyroidectomy is symptomatic disease. And to find that adenoma before you make your incision, your best localization study is the technetium-99m system EB scan. Now keep in mind, secondary hyperparathyroidism is a completely different beast. Its most common cause is chronic kidney disease. Oh, and one last thing. After you successfully perform surgery for hyperparathyroidism, you have to be on high alert for something called hungry bone syndrome. This is where calcium rapidly shifts back into the bones, causing a severe, sudden drop in blood calcium levels. Let's shift our focus below the diaphragm for Section 4, adrenal gland disorders. This is where biochemical pathways truly dictate surgical intervention. And this brilliantly illustrates our starting point for adrenal masses. Your absolute go-to imaging modality is a contrast-enhanced CT scan. But what if you just happen to find a mass incidentally? Well, the most common adrenal incidentalloma is a non-functioning adrenal adenoma. On the flip side, the most common malignant adrenal tumor is adrenocortical carcinoma, and classically, this malignancy loves to secrete excess cortisol. Speaking of hormones, let's contrast two major adrenal pathologies. Primary hyperaldosteronism is most commonly caused by an aldosterone-producing adenoma. Its absolute hallmark biochemical finding is hypokalemia or low potassium. If you suspect it, the gold standard confirmatory test is adrenal vein sampling. Now, contrast that with Cushing's syndrome. Believe it or not, the most common cause overall is actually exogenous, meaning patients taking corticosteroid medications. But the most common endogenous cause is a pituitary adenoma. To screen for Cushing's, you'll use the overnight dexamethasone suppression test, and if you happen to locate a unilateral cortisol-producing adrenal adenoma, your definitive treatment is an adrenalectomy. The adrenal medulla brings us to a really critical, highly tested tumor, the pheochromocytoma. This is an essential ward round question, guys. If an attending asks you for the classic pheochromocytoma triad on rounds, you need a reflex answer: headache, sweating, and palpitations. And if they ask how you're going to prove it, your gold standard investigation is measuring plasma-free metanephrines. Let's move to the surgical sequence and see how this builds, because the clinical sequence here is literally a matter of life and death. Your preoperative drug of choice for a pheochromocytoma is an alpha blocker, specifically phenoxybenzimine. You absolutely must administer this first. Beta blockers should be started only after adequate alpha blockade has been achieved. Why? While doing it the other way around leaves alpha-adrenergic receptors totally unopposed, which triggers a catastrophic, life-threatening hypertensive crisis. Once they're safely blocked, your definitive treatment is the adrenalectomy. But your job isn't done just because the tumor's out. The most important postoperative complication you've got to monitor for after removing a pheo is severe refractory hypotension. We've reached our final stretch. Section 5, multiple endocrine neoplasia syndromes, or MEN syndromes. All right, I know these can be confusing, so grouping these facts visually is really the best way to master them. MEN1 classically includes the 3 Ps: parathyroid, pituitary, and pancreatic endocrine tumors. Now look at the MEN2 variants. Both MEN2A and MEN2B actually share 2 major features: medullary thyroid carcinoma and pheochromocytoma. So how do you tell them apart on an exam?
Well, MEN2A includes parathyroid hyperplasia, whereas MEN2B is characterized by the presence of mucosal neuromas. Tying the MEN2 syndromes together is one critical piece of genetics. The RET proto-oncogene mutation is directly associated with the MEN2 syndromes. Knowing this single genetic marker is an absolute must-know, high-yield fact for your board
facial
exams.
fractures. When you're dealing with maxillofacial trauma, there is one rule that rules them all, and that's strictly adhering to ATLS principles. That means airway first. You absolutely must secure the airway before anything else. Only after that airway is totally definitive do we move on to investigation. And the gold standard imaging for facial fractures? That's going to be a CT scan with 3D reconstruction. Just remember, never ever rush to the scanner before that airway is safe.
Now let's rapid fire some classic exam triggers. If they ask you for the most common facial bone fractured overall, bam, nasal bone. For the mandible specifically, the most common fracture site is actually the condyle. Moving to the cheek, the most common zygomatic fracture is the zygomaticomaxillary complex, which you'll often hear called a tripod fracture. And what's causing all this? Well, the leading etiology, the most common cause of a mandibular fracture, is a road traffic accident.
Moving up to mid-face trauma, we've got the classic Leaf-Fort classifications. This is pure anatomical pattern recognition, folks. A Leaf-Fort 1 is your horizontal maxillary fracture. A Leaf-Fort 2, that takes a triangular shape, which is why it's called a pyramidal fracture. And then you have the absolute most severe, Leaf-Fort 3, which literally separates the facial skeleton from the skull base. We call that craniofacial dissociation.
So what happens when things go wrong? Well, these fractures lead to some severe functional complications. If a patient has bilateral mandibular condylar fractures, you should immediately expect an anterior open bite. Now, if they have bilateral mandibular body fractures, the greatest danger is actually airway obstruction, because the tongue just falls right back. To fix a displaced mandibular fracture, the gold standard is open reduction and internal fixation, or ORIF. And if we move up to the eye, the most common cause of an orbital floor fracture is a blowout injury. This blowout commonly traps the inferior rectus muscle, and that's exactly why the patient presents with diplopia or double vision.
To close out our trauma section, we've got to trace our nerves. The most commonly injured cranial nerve in a mandibular angle fracture is the inferior alveolar nerve, a supravital branch of V3, the mandibular division of the trigeminal nerve. Further down its path, the mental nerve pops out through the mental foramen. And hey, if you ever see cerebrospinal fluid rhinorrhea, meaning clear CSF is actually leaking from the nose after facial trauma, that is a huge red flag. It highly suggests a skull base fracture.
All right, making great time, moving right along to Section 2, odontogenic cysts and tumors. Watch out for this subtle contrast right here, because it is a classic Viva trap. If the exam asks for the most common odontogenic cyst overall, the answer is the radicular cyst, which is inflammatory. But if they sneak in one specific word and ask for the most common developmental odontogenic cyst, the answer completely flips to a dentigerous cyst. You have to read the stem carefully.
Now for the tumors. The most common odontogenic tumor overall is the odontoma. Simple enough. However, the most common clinically significant one, that's the ameloblastoma. You're going to classically find these guys located in the posterior mandible, and they present with this famous soap bubble radiographic appearance. Because they are so locally aggressive, the absolute gold standard treatment for an ameloblastoma is a wide surgical resection.
Next up, Section 3, Oral Oncology and Lesions.
Let's lock in 3 massive board facts regarding premalignant lesions. Leukoplakia, which presents as a white patch, is the most common premalignant lesion of the oral cavity. But erythroplakia, a red lesion, carries the absolute highest malignant potential. Furthermore, if your patient presents with oral submucous fibrosis, your clinical reasoning should immediately link that to a history of areca or betel nut chewing.
So when we talk about actual oral malignancies, squamous cell carcinoma, or SCC, is the big one. It's the single most common malignant tumor of the oral cavity. Where should you look first during an exam? The most common site is the lateral border of the tongue. The main risk factor driving this pathology is, unsurprisingly, tobacco use. And if you suspect SCC, the gold standard method for diagnosis is an incisional biopsy so you can secure that tissue for the pathologist.
Now, treating these cancers brings its own intense complications. Osteoradionecrosis of the jaw is a devastating condition, and it's most commonly caused by a dental extraction happening after a patient has received radiotherapy to the head and neck. For advanced disease, you can't just throw antibiotics at it. The best treatment is surgical debridement paired with the vascularized flap reconstruction to actually bring fresh, healthy blood supply back to that irradiated bone.
Moving right along to Section 4, salivary gland pathology.
Foundational surgical anatomy is absolutely key here. Wharton's duct is the one responsible for draining the submandibular gland. Stenson's duct, that drains the parotid gland. Now, the parotid gland itself is the most common salivary gland affected by tumors. And surgically speaking, it is a total minefield because the facial nerve runs right smack through it.
You've got to keep your benign, malignant, and infectious facts perfectly organized for the exam. The most common salivary gland tumor overall, which is also the most common benign tumor of the parotid, is the pleomorphic adenoma. On the flip side, the most common malignant salivary gland tumor is mucoepidermoid carcinoma. If we switch gears to salivary stones, the submandibular gland is the most common location, mainly because its duct has to travel upwards against gravity. Finally, the most common cause of acute bacterial salidinitis, that's going to be Staphylococcus aureus. Finally, we reach our fifth and last domain, severe odontogenic infections.
Consider this classic high-stakes board scenario. You have a patient presenting with massive swelling in the floor of their mouth. The diagnosis is Ludwig's angina. What is the single most immediate threat to this patient's life? The undeniable answer is airway obstruction. The swelling physically pushes the tongue upward and backward, totally closing off the pharynx. Because of this, the absolute best initial management of Ludwig's angina is always to secure the airway. Notice how this brings our clinical reasoning full circle, right back to the very first trauma principles we discussed at the start. Airway always comes first. To understand why this happens, look at the pathophysiology. Ludwig's angina specifically involves the bilateral submandibular and sublingual spaces simultaneously. It doesn't just happen out of nowhere either. The most common source is actually an underlying dental infection, specifically from the mandibular second or third molar, because the roots sit below the myohyoid ridge, giving the infection a direct path to those deep spaces.
And let's hit our 50th and final clinical fact. If you are evaluating a patient following a dental infection and they present with severe trismus, meaning an inability to open their mouth, basically lockjaw, your clinical reasoning should immediately point you toward involvement of the masticatory space. The infection is literally irritating the muscles of mastication.
And there you have it, from securing the trauma airway and fixing traps. Okay, so here's a massive trap people fall into under pressure. You have to distinguish exactly how shock first manifests. Tachycardia is for sure the absolute earliest clinical sign you're going to see, ticking on the monitor. But the skin is actually the earliest organ physically affected by the body's compensatory mechanisms. Meanwhile, the brain remains the most sensitive to prolonged hyperperfusion. You really have to know the difference here between the clinical sign you measure, the first physical organ affected, and the organ that's going to suffer the most devastating consequences if you delay.
To spot that danger instantly, our first major objective metric is the normal shock index, which sits perfectly between 0.5 and 0.7. It's calculated super simply. Just take the heart rate and divide it by the systolic blood pressure. When you're looking at a patient's vitals, just remember that any value greater than 1 strongly suggests significant circulatory compromise. It's a fantastic, rapid bedside calculation that instantly warns you your patient is in the danger zone, well before their blood pressure completely bottoms out. Moving right along to Section 2, differentiating shock. This is where it gets really interesting because we're going to unravel the complex web of hemodynamics to instantly identify the exact type of shock we're dealing with.
Let's look at how comparing hemodynamics builds our precise clinical picture. Hypovolemic shock classically presents with low cardiac output, a compensatory high systemic vascular resistance, or SVR, the lowest pulmonary capillary wedge pressure, and reduced mixed venous oxygen saturation. Now, in stark contrast, early septic shock is completely unique. It has a high cardiac output, low SVR, and actually an increased mixed venous oxygen saturation. Then you have cardiogenic shock, which stands out entirely with an elevated central venous pressure, or CVP, and the absolute highest pulmonary capillary wedge pressure of the bunch. And as a quick rule of thumb for all of this, keep in mind that oxygen delivery ultimately depends primarily on cardiac output and hemoglobin concentration.
So how do we apply this physiological data to the physical exam at the bedside? Well, warm extremities are highly suggestive of early septic shock, mostly because of that low SVR we just talked about. On the flip side, cold extremities paired with a raised jugular venous pressure, or JVP, point directly to a cardiogenic source. Now, what if you've got a raised JVP and hypotension? This is where you absolutely must listen to the chest. Clear lungs will help you diagnose cardiac tamponade, whereas absent breath sounds are the classic hallmark of a tension pneumothorax. It's really all about putting these specific puzzle pieces together in real time.
For rapid clinical reasoning, you need to lock in these classic syndromes. Septic shock is primarily a form of distributive shock. When you think obstructive shock, your mind should jump to pulmonary embolism first as the most common cause. You also absolutely have to know your triads. Beck's triad defines cardiac tamponade, while the Cushing triad indicates raised intracranial pressure. Finally, keep in mind that a cervical spinal cord injury is the most common cause of neurogenic shock, which classically and uniquely presents with hypotension coupled with bradycardia rather than the tachycardia you might usually expect.
Now that we've diagnosed the exact type of shock, let's jump into Section 3, managing trauma and hemorrhage, which is the most common cause you'll see in trauma scenarios.
Let's get our priorities crystal clear here. Hemorrhage is the #1 cause of shock and trauma, and exsanguination is the leading cause of early death. Because the risk is so massive, you must immediately use a fast scan as the very first test for any unstable blunt abdominal trauma, and when you're categorizing severity, remember that a patient hitting Class 3 hemorrhagic shock has already lost a massive 30 to 40% of their blood volume. The clock is relentlessly ticking here, guys.
To fight this kind of massive blood loss, your gold standard protocol is damage control resuscitation. This breaks down into 3 critical steps. Number 1, permissive hypotension. Number 2, hemostatic resuscitation. And number 3, culminating in rapid hemorrhage control. Make no mistake about it, controlling the bleeding is unequivocally both the most important immediate treatment and the definitive treatment for hemorrhagic shock. Fluids and blood might buy you a little time, but it's the surgery that actually saves the life. While you're running that damage control protocol, you want to aim for a target systolic blood pressure of around 80 to 90 millimeters of mercury. Doing this keeps the organs alive without blowing out any fresh, fragile clots. But, and this is a huge but, you must completely abandon permissive hypotension if a traumatic brain injury is present. TBI is an absolute contraindication here because that injured brain desperately needs a higher perfusion pressure to survive. When you transition over to hemostatic resuscitation, this ratio right here is your clinical anchor, 1:1 to 1. That's the massive transfusion ratio for packed red blood cells, fresh frozen plasma, and platelets. You aren't just giving them volume, you are replacing whole blood with balanced blood component therapy to prevent the lethal triad of trauma. Following the sequential fluid protocol is literally non-negotiable. Always start with a balanced crystalloid like Ringer's Nactate as your first line. If they aren't responding, shift immediately to your preferred blood products, packed red blood cells with balanced component therapy. If you're dealing with hemorrhagic shock that just isn't responding to fluids, give blood. Still stubbornly hypotensive, you have to suspect ongoing hemorrhage. And crucially, make sure to get tranexamic acid, or TXA, into the patient within a strict 3-hour window of the injury for it to be actually effective. Which brings us to our final act, Section 4, Resuscitation Strategies and Targets. Let's lay out our exact pharmacological strategies and the physiological endpoints we need to hit. Pharmacology requires absolute precision based entirely on the shock etiology. For anaphylactic shock, intramuscular epinephrine is your absolute drug of choice. For cardiogenic shock with persistent hypoperfusion, your initial inotrope of choice is dobutamine. And for septic shock, norepinephrine is your go-to initial vasopressor, but hear this clearly, it should generally be started strictly only after adequate fluid resuscitation has been achieved. You can't squeeze an empty tank. Tracking vital biochemical markers is key to knowing if what we're doing is working. Elevated lactate is your earliest laboratory evidence of severe shock, and serum lactate is the most reliable biochemical marker of tissue hyperperfusion we have. But a single snapshot measurement isn't enough. Lactate clearance over time is actually the best marker of successful resuscitation. Finally, we look at the serum base deficit, which gives us a highly accurate gauge on the overall severity of the shock state. Honestly though, back at the bedside, you don't always have time to wait for labs. Urine output is your most sensitive clinical indicator of adequate resuscitation. You are aiming for a strict target of at least 0.5 milliliters per kilo per hour in adults. Failure to meet these basic tissue demands for too long results in irreversible shock. This is a catastrophic state defined by persistent cellular injury which stubbornly continues even after you've managed to successfully restore the patient's circulation. As we wrap up this... Okay, let's dive into this. We all know albumin, right? It's the most abundant plasma protein. But here's the catch. It has a really long 20-day half-life. If a patient's nutritional intake basically dropped off a cliff 3 days ago, their albumin might still look totally normal. Contrast that with prealbumin, which is also known as transthyretin. With a super short 2 to 3 day half-life, this is absolutely your best indicator of visceral protein stores and acute nutritional changes. Examiners love to test if you know to check prealbumin for those real-time updates.
But, we really have to look beyond just the lab draws. The Subjective Global Assessment, or SGA, is the most reliable indicator of a patient's long-term nutritional status. Now, if you need to know exactly how many calories a really complex patient is burning, the gold standard to assess their resting energy expenditure is indirect calorimetry. And this last point, it's massive for your actual clinical practice. If you are asked what the single best predictor of post-operative complications due to malnutrition is, it's significant recent weight loss. It's not a lab value. It's right there in the clinical history.
Let's see how this builds into the specific hard numbers you absolutely must commit to memory. A BMI of 30 or above indicates obesity, while anything under 18.5 is underweight. But remember how we just said significant recent weight loss is our top predictor of complications? Well, the exact threshold for severe malnutrition is a weight loss of greater than 10% over a 6-month period. Lock that specific time frame in your brain.
Moving right along to Pillar 2, choosing the feeding route.
You've definitely heard the old surgical mantra, if the gut works, use it. Enteral nutrition is the preferred route, mainly because it maintains gut mucosal integrity. It's the best initial nutrition, even early after major gastrointestinal surgery, and we definitely prefer it in short bowel syndrome whenever feasible. However, and this is a hard stop, the absolute contraindication to enteral feeding is mechanical intestinal obstruction. You simply cannot push food through a blocked pipe.
Let's apply this to some classic clinical scenarios you are guaranteed to see on the wards and in your Viva questions. If feeding is needed for more than 4 weeks, the preferred enteral route is a PEG tube. If the patient has a gastric outlet obstruction, meaning food literally can't leave the stomach, you just bypass it with jejunostomy feeding. And this last one elegantly illustrates a highly tested point. What about severe acute pancreatitis? For years, people thought you had to rest the gut completely, right? Actually, no. The preferred support is enteral feeding, specifically utilizing the nasojejunal route to bypass the pancreatic stimulation phase.
All right, Pillar 3, managing feeding complications.
Now, what's really interesting about this slide is the careful distinction you need to make between complication types for total parenteral nutrition, or TPN. If you're asked for the most common complication overall, it's a catheter-related bloodstream infection. You have a direct line sitting in a central vein, and bugs just love that. But if the question specifies the most common metabolic complication, the answer is hyperglycemia, because we're pumping a massive amount of dextrose directly into the blood. Also, just a quick note that the preferred lipid source for TPN is an intravenous lipid emulsion. This brings us to literally the most dangerous complication in a severely malnourished patient, refeeding syndrome. You must follow a strict sequence here. Step 1. Identify the severe malnutrition, keeping in mind that hypokalemia is the most common electrolyte abnormality you'll see. Step 2 is absolutely critical. You must administer thiamine, that's vitamin B1, before you give any glucose. If you reverse that order, you risk triggering Wernicke encephalopathy. Step 3, as you begin feeding, closely monitor for refeeding syndrome. The absolute hallmark of this is a dangerous drop in phosphorus, known as hypophosphatemia.
Next up, Pillar 4, essential vitamins and minerals.
Okay, you need to know these cold. Rapid fire time. As we just saw, thiamine or B1 deficiency causes Wernicke encephalopathy, and it's actually the very first vitamin deficiency to develop in prolonged alcoholism. Vitamin C deficiency causes poor wound healing. Vitamin D leads to osteomalacia. Vitamin A deficiency presents as night blindness. Vitamin K is crucial for clotting, so its deficiency naturally causes a bleeding tendency. Niacin, or B3, is famous for the classic 3 Ds, dermatitis, diarrhea, and dementia. And, brilliantly illustrating surgical anatomy, the most common deficiency after a terminal ileal resection is vitamin B12. Why? Because that's exactly where it gets absorbed.
Continuing our micronutrient drill, let's talk trace elements. The most common trace element deficiency in prolonged TPN is zinc, which notoriously causes poor wound healing as well. If a patient on long-term nutritional support suddenly develops new-onset heart issues, you should immediately think of selenium deficiency, which causes cardiomyopathy. Copper deficiency manifests hematologically as anemia and neutropenia.
And rounding out this list, the single most important immunonutrient you can provide for wound healing is the amino acid arginine.
And finally, Pillar 5, cellular fuels and metabolism.
It's honestly brilliant how specific organs are finely tuned to prefer entirely different fuel sources. For example, the major fuel used by the enterocytes of the small intestine is glutamine. Meanwhile, further down the tract, the colonocytes prefer short-chain fatty acids, especially butyrate. Under normal conditions, the brain's preferred fuel is strictly glucose. But what about the myocardium, your heart muscle, when it's at rest? Its main fuel is actually free fatty acids. Knowing these distinct cellular preferences is absolutely a hallmark of a top-tier surgical candidate.
Let's zoom out and look at the metabolic state of the entire body. Nitrogen balance is positive when a patient is in a state of growth and recovery. Basically, they are actively building tissue. Conversely, nitrogen balance is negative in states of severe trauma and sepsis, where the body is rapidly breaking down proteins just to survive. We can also measure exactly what fuel the patient is actively burning using the respiratory quotient, or RQ. The RQ for carbohydrates is a clean 1.0, whereas the RQ for fats is 0.7.
So, with those metabolic demands shifting wildly, how much protein do we actually give a critically ill adult? Exactly 1.2 to 2.0 grams per kilogram per day. Please do not underfeed protein in the ICU. This specific range is an incredibly common Viva question, so definitely lock it in.
So, the crucial point is this. Why are we doing all this? Why meticulously calculate nitrogen balances, memorize half-lives of proteins, and endlessly debate the precise routes of feeding? The most important goal of perioperative nutrition is simply this: to reduce postoperative complications and preserve lean body mass. Everything we do serves that one ultimate clinical goal.
Initial resuscitation and mortality.
It's really all about understanding the timeline of mortality. As we just established, shock is your primary threat early on, right there in that critical under 24-hour window. But if your patient survives that, the threat completely shifts. After the first week, sepsis actually becomes the leading cause of death. And while all of this is happening, the patient's body is going through a massive hypermetabolic response, which is driven heavily by a huge surge of catecholamines. We've got to keep that hypermetabolism in mind because it dictates our nutritional strategy later on.
Now, to even begin our resuscitation, we first have to estimate the total body surface area, or TBSA, that's actually been burned. For adults, you'll use the classic rule of nines, and definitely remember that an entire adult lower limb is 18%. For children, though, we prefer the London Browder chart because it accounts for their proportionately larger heads. And what about scattered, irregular burns? Just use the patient's palm, including their fingers. That roughly equals 1% TBSA. So how exactly do we replace all that lost fluid? The gold standard for initial resuscitation is the Parkland formula. And the fluid of choice in the first 24 hours? That's Ringer's lactate. Now listen closely because here is a classic Viva trap regarding pacing and timing. You absolutely must give 50% of that calculated fluid volume in the first 8 hours. And here's the kicker. You calculate that start time from the exact time of the burn injury, not the time they rolled into the hospital. So, if they arrive 2 hours post-injury, you've only got 6 hours left to get that first 50% in. You know, what's really fascinating here is that the absolute best endpoint for adequate resuscitation isn't their heart rate, and it isn't their blood pressure. It is meticulously tracking target urine outputs. This is hands down the most reliable marker of organ perfusion. For your adult patients, the target is 0.5 milliliters per kilogram per hour or greater. For kids, you need to push that to 1 milliliter per kilogram per hour or greater. This is exactly why Foley catheters go in early. To combat that intense catecholamine-driven hypermetabolism we mentioned earlier, getting nutrition on board is paramount. The biggest requirement, high protein and high calorie nutrition. And the best route to deliver it is early enteral feeding. You always want to use the gut if it works because it helps prevent bacterial translocation. Also, keep your referral criteria top of mind. Any burns to highly functional or cosmetic areas. We're talking the face, hands, feet, genitalia, or right over major joints, those mandate an immediate transfer to a specialized burn center. Moving right along to Section 2, airway and inhalation injuries. This is an area where rapid clinical reasoning literally saves lives, because airway edema can worsen rapidly over just a few hours. The golden rule: never wait for the airway to close. If a patient presents with progressive stridor, that demands immediate airway protection.
If you see facial burns paired with clinical signs like hoarseness, that's your cue for early endotracheal intubation, way before the swelling prevents you from passing a tube. And if you need to definitively confirm an inhalation injury, fiber optic bronchoscopy is your gold standard investigation. It yields the most reliable physical signs of deep airway damage.
Get ready, because this is an incredibly common board trap comparing two fatal smoke inhalation toxins. You absolutely have to be able to differentiate these clinically. If you see cherry red skin, that points straight to carbon monoxide poisoning. The best diagnostic test is a carboxyhemoglobin level, and the treatment is straightforward: 100% oxygen. On the flip side, if your burn patient develops a severe, unexplained lactic acidosis after smoke inhalation, you need to suspect cyanide poisoning. The specific antidote for cyanide is hydroxycobalamin. All right, Section 3, burn depth and surgery. Understanding the depth of the burn is absolutely crucial because it entirely dictates our surgical approach. A superficial, partial thickness burn is incredibly painful and usually presents with characteristic blisters. But on the totally opposite end of the spectrum, a full thickness burn is distinctly painless and has this leathery texture to it. You might be wondering, why is it painless? Well, it's because the thermal injury has completely obliterated the nerve endings in the dermis. The real danger with that tight, unyielding leathery skin is that it can act just like a tourniquet. If you have a circumferential full-thickness burn on a limb and you suddenly lose distal pulses, you need to perform an immediate eschorotomy to release that pressure. And the exact same logic applies to full-thickness chest burns that restrict a patient's ventilation. A chest eschorotomy allows the chest wall to actually expand. Oh, and keep a close eye out for iatrogenic complications. If urine output suddenly drops to oliguria and you've got abdominal distension despite pumping them full of massive fluids, you really need to suspect abdominal compartment syndrome caused by your own resuscitation efforts. We've got a ton of high-yield surgical pearls to unpack here. The definitive treatment for deep circumferential full-thickness burns is early excision and skin grafting. As a general rule of thumb, if a burn is taking longer than 3 weeks to heal, it's usually going to require grafting. For deep full-thickness burns, they're best managed with a split-thickness skin graft. And remember, an autograft, which is the patient's own skin, is literally the only permanent skin substitute. The place we take that skin from, the donor site, heals by re-epithelialization. Finally, keep in mind that deep dermal burns are the most common cause of debilitating contractures. We have to aggressively prevent those through early splinting and really dedicated physiotherapy.
Next up, Section 4, infections and wound care. So, the patient has survived the initial shock, but now they face a microscopic enemy. Timing is everything when you're trying to spot an infection. If you see a healing partial thickness burn suddenly convert to a full thickness appearance, pay attention. That is your earliest clinical sign of trouble. Microbiologically, the timeline of the bugs shifts as well. The initial colonizer of burn wounds is usually Staphylococcus aureus. But if late burn wound sepsis develops after that first week, the fatal culprit is most often Pseudomonas aeruginosa. How do we choose our topical weapons? It all comes down to specific clinical indications. Silver sulfadiazine is your standard, everyday workhorse for most burn wounds. But if you're dealing with thick, unexcised tissue, mafenide acetate is chosen for its superior deep eschar penetration. Just watch out because it can cause metabolic acidosis. Lastly, for delicate facial tissue, bacitracin is the preferred safe agent.
And finally, Section 5, special burns and complications.
Let's talk about electrical burns, because high-voltage injuries are notoriously deceiving. The surface damage, those entry and exit wounds, might look pretty minimal, but the underlying pathophysiology is a different story. It commonly causes massive, deep muscle necrosis as the current travels along the bone. And because that current also travels right through the heart, the most common cause of death is actually a cardiac arrhythmia. Because of this, getting an immediate ECG is a strictly mandatory investigation for these patients. There's no skipping it. Now, if that electrical burn patient begins passing brown urine, your target urine output shifts dramatically. You need to bump it up to 1 to 1.5 milliliters per kilogram per hour. That brown urine is a huge red flag suggesting myoglobinuria from all that massive deep muscle breakdown. You literally have to aggressively increase fluids to flush those renal tubules and prevent acute renal failure. When it comes to chemical burns, there's one famous exception to the general rule you need to know. Step 1 for almost all chemical burns is immediate, copious irrigation with water to dilute and remove the agent. But hydrofluoric acid is the big exception. It requires specific treatment with topical calcium gluconate.
Why? Because those fluoride ions aggressively bind to tissue calcium. This causes massive systemic hypocalcemia that can quickly trigger fatal arrhythmias if you don't neutralize it.
Classification system. Before we even look at specific machines or chemicals, we have to know exactly how to decide what level of clean is actually required. That's where the Spalding classification comes in. It's essentially a brilliant way to organize our clinical decision-making based on patient contact. So, if an item is critical, think surgical instruments entering sterile tissue or the vascular system, it absolutely 100% needs full sterilization, no exceptions. Now, if it's semi-critical, like something contacting mucous membranes, we can step it down to high-level disinfection. And for non-critical items, those are things that only touch intact skin, so low-level disinfection is totally fine there. But keep this in mind. If an instrument is contaminated with bacterial spores, throw the usual category out the window, because that instantly mandates full-blown sterilization. Moving right along to Section 2, Physical Sterilization and Indicators.
Now that we know what needs to be sterilized, let's look at the actual physical methods we use in the hospital. The big takeaway here is understanding the mechanism of action. The absolute gold standard, that's steam sterilization, better known as autoclaving. It uses saturated steam under immense pressure to literally cook the bugs, killing them via protein denaturation. It's incredibly effective. But, we can't autoclave everything. For stuff like powders and oils, moisture's a huge problem. So for those, we have to pivot to dry heat. And here's a high-yield clinical fact you'll definitely want to remember. Unlike the steam of an autoclave, dry heat kills microorganisms mainly by oxidation. It's a completely different mechanism.
All right, you really need to commit these exact parameters to memory for your exams. Standard autoclaving takes 15 minutes at 121 degrees Celsius with 15 psi of pressure. Now, if you're in a pinch in the OR, you might run a flash autoclave cycle. That hits a much hotter 134 degrees and only takes 3 to 4 minutes. Super fast, right? In stark contrast, standard dry heat sterilization requires a massive temperature of 160 degrees Celsius for a full 2 hours. That really puts it into perspective. The pressurized steam in an autoclave makes protein denaturation incredibly fast and efficient compared to the slow burn of dry oxidation.
But how do we actually know the autoclave is working properly? Before we trust that machine with critical surgical equipment, we run a daily diagnostic called the Bowie-Dick test. Now, this isn't for checking if bugs are dead. Its specific job is to evaluate air removal in pre-vacuum autoclaves. Think about it. If there are air leaks, the steam just can't penetrate the surgical packs, and the whole sterilization process completely fails.
So once the machine is actually running, we have to monitor the individual packs using indicators. You've got to know the clear distinction here. Chemical indicators, they just assess that a pack was physically exposed to the sterilization conditions, like the heat or the steam. They'll change color, sure, but they don't actually prove the bugs are dead. Biological indicators, on the other hand, are the real deal. They assess actual sterility assurance. For steam autoclaves, we use the super tough spores of Geobacillus stereothermophilus. If you manage to kill those incredibly resistant spores, you have absolute, undeniable proof of sterility.
Ultimately, what is our goal here? Our target sterility assurance level, or SAL, for medical devices must reach 10 to the negative 6th power to be considered legally and medically safe. To put that into perspective, that means out of 1 million sterilized items, only one single microorganism might survive. It's a 1 in a million chance, and it is our absolute gold standard metric for patient safety.
All right, let's switch gears and head into Section 3, Chemical Sterilization and Disinfection.
We have to tackle chemical methods because, frankly, some highly delicate instruments physically cannot withstand the intense heat, pressure, or moisture of an autoclave. For those delicate, heat-sensitive plastics, ethylene oxide gas is your best friend. We monitor it using the biological indicator Bacillus atrophaeus. But there's a catch, and it's a major clinical disadvantage you must know. It requires a really long aeration time. The gas is highly toxic, so it needs plenty of time to dissipate before the equipment can be safely handled. As a great alternative, we use plasma sterilization, which relies on hydrogen peroxide gas plasma. It's incredibly fast, it leaves no toxic residue whatsoever. But, and this is a big but, it is strictly contraindicated for any cellulose-containing materials like paper or linens. They absorb the hydrogen peroxide, and it literally just causes the cycle to abort.
Now, when we drop down from full sterilization to high-level disinfection, glutaraldehyde is our go-to. It's specifically the best method for endoscopes. But what about good old-fashioned alcohol? While for alcohol to be effective as a disinfectant, it absolutely requires a minimum concentration of 70%. But remember our Spalding classification from earlier? Alcohol is totally, completely ineffective against bacterial spores. So if your instrument is contaminated with spores, wiping it down with alcohol is basically doing nothing.
And speaking of stubborn contaminants, we have to talk about the most resistant microorganisms in existence, prions. Normal sterilization doesn't even make them flinch, because they're these wildly misfolded proteins that are incredibly resistant to standard denaturation. Prion decontamination requires a super rigorous two-step process. Step 1, you have to treat the item with harsh sodium hydroxide. Step 2, you follow that immediately with prolonged autoclaving. You really have to hit them with everything you've got.
To round out our alternative non-heat methods, you're definitely going to see these two pop up on board exams. Remember that UV light has really poor penetrating power, so it's strictly used for surface and air disinfection in the OR. Gamma radiation, however, is a whole different beast. It has excellent penetrating power and is the industry standard for sterilizing factory-sealed disposable medical equipment. Think things like syringes and sutures, long before they ever reach the hospital doors.
Awesome. Moving right along to Section 4, preoperative skin and scrub. With our instruments now completely sterile, we've got to turn our attention to preparing the surgical team and the patient. When painting the patient's skin before making an incision, chlorhexidine and alcohol is widely considered the most effective preoperative skin antiseptic. Its major clinical superpower? Persistent residual activity. That basically means it keeps actively killing bacteria long after it dries on the skin. Now, povidone iodine is also very common, but it comes with a major weakness you need to watch out for. It is easily inactivated by organic matter, like blood or pus. Now, let's talk about the surgeon's hands. The whole point of the surgical hand scrub is primarily to remove transient flora. That's all the random bacteria you picked up from touching doors, charts, or your coffee cup. However, let's be real, it is physically impossible to sterilize living human skin. The scrub leaves behind the deep-seated resident skin flora, and of those, Staphylococcus epidermidis is by far the most common one hanging around.
Okay, here is a highly practical, everyday point regarding patient prep. If you have to remove hair before a surgery, you must always use electric clippers. Why? Because shaving with a standard razor actually causes microscopic abrasions in the skin. Bacteria just love to multiply in those tiny cuts, and that directly and significantly shoots up the patient's risk of getting a surgical site infection. Just don't use a razor.
And that perfectly sets up our final part, Section 5, preventing surgical site infections. Let's bring all these principles together in the operating room to prevent the ultimate postoperative complication, surgical site infections, or SSIs. Now, these are most commonly caused by Staphylococcus aureus. But where's it coming from? Well, the most common endogenous source, meaning from within, is actually the patient's own skin flora getting pushed into the wound. On the flip side, the most common exogenous source, meaning from outside the patient, is, well, us, the operating room personnel. This is exactly why our scrub, our surgical attire, and our aseptic technique have to be absolutely flawless. To combat these sources, we heavily rely on appropriate antibiotic prophylaxis and super strict asepsis. You should be administering prophylactic antibiotics ideally within 60 minutes before making the surgical incision. Inside the room, instrument packs should be opened immediately before use, not an hour before while you're setting up. And how do you actually know if a stored pack is still sterile? Listen to this. The sterility of a wrapped instrument doesn't depend on some arbitrary expiration date. It depends solely on the physical integrity of the package. If there's a tiny tear or even just a water spot, it's contaminated, no questions asked.
Once that surgery actually begins, the rules of the sterile field are absolute. Sterile gloves, they act as your sterile barrier protection. And the golden rule here is that the entire sterile field is considered compromised if even a single non-sterile object touches it. Oh, and here's the fun fact about surgical masks. While we might naturally think they're there to protect us from the patient, their primary purpose in the OR is actually to prevent droplet contamination from the surgical team's own mouths and noses from falling directly onto the operative field.
Surgical site and necrotizing infections. So if you're ever asked about the most common organism behind a general surgical site infection, the answer is always Staphylococcus aureus. But you've got to watch out for the clinical pivot here. The second the clinical stem mentions colorectal surgery, the flora changes, right? Your most common organism shifts immediately to Escherichia coli. Oh, and while we're talking about S. aureus, lock this fact in. It's also the definitive answer for the most common organism causing toxic shock syndrome.
Remember, location and procedure type completely dictate your microbial suspect. Now, when we're looking at rapidly progressing, life-threatening infections, timing is literally everything. For necrotizing fasciitis, your main culprit is group A streptococcus, which you might also know as Streptococcus pyogenes. Now, what's the absolute earliest clinical feature you have to look for? It's pain entirely out of proportion to the physical findings. When you see that, you don't wait. The gold standard treatment is emergency surgical debridement. Compare that to gas gangrene. If you see gas in the soft tissues on imaging, that screams clostridial myonecrosis, mostly caused by Clostridium perfringens. The definitive treatment? Just like necrotizing fasciitis, it's urgent surgical debridement. Time is tissue, people.
And speaking of necrotizing infections, we absolutely cannot forget Fournier gangrene. The mechanics here are fascinating, but incredibly deadly. You know, the most common source of this perineal infection is actually an anorectal infection, but unlike the previous two we just talked about, Fournier is fiercely polymicrobial. Because of the complex anatomy and the aggressive nature of these mixed bugs, the gold standard treatment is immediate, aggressive surgical debridement. You just have to clear out that dead tissue if you want to save the patient.
Moving on to our second section, let's talk about hand and extremity infections, going from paronychia all the way to carnival signs. These are classic Viva questions, so pay close attention.
All right, quick warning, these next infections are among the most common rapid-fire exam questions you're going to face. We're looking at the temporal presentation of peyronia, that really painful infection right around the nail fold. If the clinical picture is acute, your brain should immediately scream Staphylococcus aureus. But if the presentation is chronic, lingering over weeks, you have to shift your gears completely away from bacteria. The most common organism for chronic peyronia is actually a fungus, Candida albicans. So acute equals staph, chronic equals Candida, simple, clean, and highly testable.
Now, what's really interesting about this next topic is how a classic eponymous sign can diagnose a surgical emergency. I'm talking about Cannavale signs. If you see a finger held in slight flexion, fusiform swelling, tenderness along the tendon sheath, and severe pain on passive extension, those are Cannavale signs. They are absolutely diagnostic of pyogenic flexor tenosynovitis. The organism? Yep, S. aureus again. And the gold standard treatment? Urgent surgical drainage with antibiotics to prevent permanent loss of hand function. Just as a quick, high-yield side note here, if you see a felon, which is a pulp space infection of the fingertip, that's also driven by S. aureus.
All right, let's pivot to Section 3, bone and joint infections. I want to prime your mind here to focus on exact diagnostic pathways for osteomyelitis and septic arthritis.
Let's step through the exact clinical pathway for osteomyelitis. Step 1, the most common organism, unsurprisingly, is Staphylococcus aureus. But here is exactly where exams try to trick you. If they ask for the gold standard early investigation, meaning the best imaging modality to catch it fast, the answer is an MRI. However, if they ask for the gold standard for definitive diagnosis, imaging just isn't enough. You actually need tissue. The answer is a bone biopsy with culture. Never, ever confuse early imaging with definitive diagnosis.
Now let's mirror that same logic for septic arthritis. The most common organism remains Staphylococcus aureus, but your critical pivot point in clinical reasoning here is the investigation. The gold standard is a joint aspiration. You have to tap that joint, analyze the fluid, and get your white count and gram stain. Once it's confirmed, the definitive treatment is surgical drainage combined with the right antibiotics. You have to do this to save that articular cartilage from being completely destroyed.
I want to take a second and deliver this next fact with the clinical gravity it really deserves. When you're dealing with infected diabetic feet, you are almost always dealing with a polymicrobial assault. It's a severe, limb-threatening situation. But beyond the limb itself, the systemic risk is absolutely catastrophic. The most common cause of death in patients with a diabetic foot infection is sepsis. A localized issue in the toe can absolutely bring down the entire system.
Let's transition into Section 4, wounds, lines, and fever. This is all about post-operative clinical troubleshooting, which is a massive area for clinical reasoning.
Examiners absolutely love testing your troubleshooting skills here. Let's knock out bite wounds by cross-referencing the source with the organism. If a patient comes in with a dog or cat bite, the classic pathogen you're looking for is Pasteurella multicida. Now, if it's a human bite, which is often a clenched fist injury, the culprit is Eikenella corrodens. But here's the beautiful part. Regardless of whether it was a dog, cat, or human, the universal drug of choice for prophylaxis is amoxicillin clavulanate. Easy to remember.
So the crucial point when troubleshooting post-op fever is that timing dictates your entire differential diagnosis. If a patient spikes a fever within the first 24 hours after surgery, it's overwhelmingly due to the body's natural inflammatory response to the surgical trauma itself. It's not an infection. Do not panic and just throw broad-spectrum antibiotics at them. However, if that fever occurs after post-op day 5, your clinical suspicion must shift heavily toward a surgical site infection. When we assess foreign body infections, let's look at intravascular catheters first. The gold standard diagnosis here is blood cultures, and the bug that absolutely loves sticking to that plastic is Staphylococcus epidermidis. Now compare that to prosthetic joints. Overall, the most common organism is S. aureus. But if it's a late-presenting infection, say months or even years later, S. epidermidis actually sneaks back in as the main culprit. And your diagnostic gold standard for that joint? Joint aspiration with culture. Moving down into the abdomen for section 5, intra-abdominal and biliary sepsis. This is where anatomy directly dictates your microbiology and your surgical management. So, the most common cause of an intra-abdominal abscess after surgery is an anastomotic leak. You're going to find it with the gold standard, a contrast-enhanced CT. Meanwhile, a pyogenic liver abscess is most commonly driven by E. coli coming right up from the portal circulation. But notice the treatment for both. The absolute hero intervention for localized intra-abdominal and pyogenic liver abscesses is image-guided percutaneous drainage, combined with antibiotics, of course. And this brilliantly illustrates one of the most vital surgical emergencies you'll ever face, acute cholangitis, which is most commonly caused by E. coli. You absolutely must know Charcot's triad: fever, jaundice, and right upper quadrant pain. Now, if the patient also develops hypotension and an altered mental status, they've crossed over into Reynolds pentad. This indicates severe ascending cholangitis with sepsis. The definitive life-saving treatment here: urgent biliary decompression, typically via ERCP to unblock that infected duct. Let's quickly compare two types of peritonitis. Spontaneous bacterial peritonitis usually happens in cirrhotic patients, and the most common organism is E. coli. It's a medical issue. But secondary peritonitis, that is a full-blown surgical crisis. The cause is a perforated hollow viscus. Think of a blown appendix or a perforated ulcer, spilling bowel contents straight into the abdomen. The gold standard treatment here isn't just antibiotics. It requires aggressive source control with surgery to patch or remove the leak, plus those antibiotics. Which brings us to our final section, the core principles of sepsis. Let's talk about the absolute golden rule of surgical sepsis. I want you to burn this single rule into your memory: source control. Whether it's debriding necrotic fascia, draining a liver abscess, taking out a perforated appendix, or unblocking a biliary tree with ERCP. Listen to me. All the broad-spectrum antibiotics in the world are utterly useless if you leave the source of the infection festering inside the patient. Early source control with appropriate antibiotics is the cornerstone of treating surgical sepsis. It is the single most important principle in managing any surgical infection. So I'll leave you with this question to ask yourself the next time you face a raging infection on the wards. How will you get source control today? Thanks for joining this explainer, and I'll catch you in the next one.